Okay, we'll get started. We just have a little bit left to go for Pulm, and then we're done with Pulm, and then we'll have a case study review and a Kahoot to review. So, like I said yesterday, there's a lot of PEs in this section. Don't confuse them. This last one is the pulmonary embolism, still a PE, pleural effusion, pericardial effusion. Physical exam, they're all PE, so get them straight when you're writing them. So clinical presentation. So material from the venous system gets transported up through the pulmonary circulation. Eventually, whenever the size of that clot is bigger than the size of the lumen, it's going to get stuck. And it just keeps going until it gets to the right size vessel, and then it gets lodged. So we have lumen obstruction and perfusion obstruction. So which way do you think the VQ ratio is going to go in these patients where they have a perfusion problem? It's going to go up or down? Up. Way up. Remember, the top number is going to get a lot larger now compared to the bottom. So the number goes up. Normally, pulmonary circulation can remove these venous emboli, but when you have a really, really big one, it can't anymore. And obviously, it's going to put you in a big stress on the heart because now what's going to skyrocket on the right side of the heart? Now that we have a fixed obstruction in the pulmonary system, afterload is going to skyrocket, putting a lot of stress on that right ventricle. More than 95% come from deep vein thrombosis in the lower extremities. So 95% of PEs, if they come in with a PE, chances are they've got a clot in their legs as well. You got to find it. Most prevalent risk factor, immobilization. Okay, remember we talked about Virchow's triad. So the three things that we'll talk about in a second, one of them is venous stasis. Blood's not moving anywhere. Immobilization after surgery is a big one. That's why we give those SCDs, the sequential compression devices on the calves, to keep squeezing to allow the blood to keep moving so you don't develop a clot. Remember, clots form in blood that doesn't move. That's why in atrial fibrillation, that left atrial appendage, that blood just sits there because the atrium are not squeezing, they just quiver. They're fibrillating. Blood sits there in left atrial appendage, it's got a clot. You go into a normal rhythm, that clot comes out, now you got a stroke. Same thing happens on the left side. Risk of fatal PE may be as high as 5%, so you have to do some prophylactic therapy. We talked about SCDs being one of them. Another thing they do is just give you heparin or Lovenox in the hospital. These are usually given via like IV or injection. Easy to do in the hospital. They're very fast working, and they're going to help prevent clotting. Malignancy and tissue damage at surgery are the two most common causes to activate this whole coagulation cascade. You're causing an injury to vessels. They're being exposed to the outside environment because you're having surgery. Cascade of coagulation starts. And if you're in that hypercoagulable environment, your propensity to get a clot goes up. So we know this venous thrombi has a bunch of stuff in it. We know the fibrin's there, red blood cells. You all get stuck in this little matrix. The hemodynamic effects of the clot depends on the size of the obstruction. If it's a whole tree of vasculature that you blocked off, it's going to have a much worse outcome. But if it's a very small clot and it gets lodged in these very, very small arterioles, the territory that you're losing, just like in a heart attack, if you have an occlusion in the left main, the LAD circumflex are going to be affected by it. If the clot wedges itself in the circumflex, the LAD is still fine because it's not where the clot is. So the bigger the clot, the bigger the territory you're going to lose, the bigger the loss of perfusion. So that Q number starts to go down. Without any pre-existing cardiopulmonary disease, pulmonary artery pressure will increase in proportion to the circulation occluded. More parts that are occluded, the more stress is going to be placed on that right ventricle. You start seeing RV strain. Have you guys learned about T-wave strain yet? So what is strain? What does it look like if you have T-wave strain? Inverted T-wave. So the QRS is positive, the T-wave is negative. Or if the QRS is negative, the T-wave is positive. In a normal EKG, the T-wave and the QRS should be in the same direction, both positive or both negative. When they're flipped, sometimes you get it's called RV strain. We know right ventricle strain because we're pushing against a higher afterload at the pulmonary system. So you'll see some EKG changes, some T-wave changes. Pulmonary circulation may be able to adapt to increased flow. Remember, normally at rest, only the bottom third of our lung is actually being perfused. We still have upper 2/3 waiting to be opened up as a backup. So because one area is blocked off, sometimes the lungs can open up other arterioles to allow blood to perfuse and still get adequate oxygenation. Without any with pre-existing cardiopulmonary disease, the increase in pulmonary artery pressure doesn't correlate with the severity of the embolization. So you may think that they're okay, they're not really hemodynamically compromised, but because they have underlying conditions, it's actually a lot worse. And these patients are often too unstable for angiography to see where these issues are. So VQ perfusion, okay, reduced or absent pulmonary perfusion distal to the site of the occlusion is proportionate to lung segments with high VQ ratios. So the VQ ratio goes up due to no blood flow. With complete occlusion, VQ ratios can reach infinity. They keep going up and up and up and up, and represents alveolar dead space. Okay, alveolar dead space. We're being ventilated, but we're not perfused. So ventilation's at 5 or 4 liters per minute. Perfusion goes to 0, almost to 0, so that number goes almost to infinity. It just keeps going higher and higher. And obviously, when we have this problem with perfusion, we know we can't get rid of CO2 adequately anymore, so we start hyperventilating to try and get that CO2 off by breathing faster. So the patient will become tachypnic, faster breathing to try and blow off all that CO2 that they normally can't do now because the surface area for diffusion has been reduced. We cut off a whole tree of vasculature due to a DVT-PE. They're not being perfused. We still have to get rid of the carbon dioxide. Let's breathe faster to promote more ventilation to get rid of that CO2. Hypoxemia makes sense. Obviously, low O2 sat, low perfusion, less gas exchange occurring. Many will have an O2 sat over 90 though. It looks deceiving, but it's still a PE. We'll show more pictures about that in a minute. This talks about the types of emboli. Not all of them are necessarily clots. The most common is the thromboembolus. So it's a venous thrombi that broke off and traveled, and now it's called an emboli. If you have an air embolism, okay, when air gets into your body, it's a bubble, which is like a clot. And if it floats around, gets wedged in a smaller vessel, it will cause a clot via air. Amniotic fluid can also do it if it's mixed up during delivery. Fat embolism occurs usually with like long bone fractures or liposuction. If you're doing liposuction and you are in a vessel and the fat gets sucked into the vessel, that big glob is a clot and will go anywhere in the body and hits a small vessel, it clots it up. Septic emboli. Okay, you'll learn about tricuspid valve endocarditis, valvular endocarditis. It can happen on the tricuspid valve as well, which is the main culprit where the vegetation occurs. So you're already on the right side of the heart, right? We're on the tricuspid valve. So if a piece of that bacteria breaks off, it goes traveling through the lungs and gets lodged. So it's a septic emboli. And tumors, usually renal cell carcinomas, with invasion, they can cause some sort of occlusions as well with these emboli. So an emboli means it's traveling. The thrombus or the thrombi is stationary. The thrombus is in the leg, deep vein thrombosis, and then you have a pulmonary embolism due to that. So here's our Virchow's triad. Venous stasis, that's your immobilization after surgery. If you're dealing with geriatric patients and you know they're bedridden from now on, what are you going to do about preventing clots? These are things you start thinking about when you're talking about patient education. Injury to vascular wall, this could be prior surgeries, illnesses, and hypercoagulability. Is your body more prone to clotting than other people? Genetic factors, or if you're septic, the hypercoagulability scale drops in the favor of more clots. So these are the 3 risk factors. You got to know this stuff as far as the things that will cause you to form a thrombosis. So these are the different things that will fall under those categories. So venous stasis, bed rest, immobility, arrhythmias. Okay, atrial fibrillation causes stasis of the blood in that left atrial appendage. Blood's not moving, it's static. Prolonged air travel. Someone says they flew for 20 hours and they didn't get up and walk around for 20 hours. That could be enough to put people in clots. Obesity will do it as well. Hypercoagulability. Oral contraceptives. Okay, will put you in a hypercoagulable state, pregnancy, polycythemia, and cigarette smoking. Vessel wall damage, here's your trauma, penetrating wounds, fractures of your long bones, surgery, burns. We talk about burns causing a lot of problems with the skin. It also causes vessel wall damage from all the exposed areas to the air. So, for example, on a test, which you already had in cardio, was very similar to this one, right? I said, I think it was a question about the patient was immobile. They had surgery, and now they're in bed, they broke their leg or whatever. They can't move anywhere, they're stuck. So if I said, what's the cause of the clot for this patient, or what's one of the insults, if I said it was because of bed rest, it's venous stasis. But I could put on there hypercoagulability, I could put vessel wall damage, which are correct as far as leading to a DVT to form, but the question I asked you was about bed rest. And because I asked about bed rest, the answer is venous stasis. Makes sense how what I'm asking for which best result, what's the best answer for the question that I'm given. So clinical manifestations, there's a classic triad, but it's actually like in a minority of cases actually have this triad. Sudden onset of dyspnea, pleuritic chest pain, and hemoptysis are the 3 triad for a PE. They may or may not have evidence of a DVT in the lower extremity, swollen, red, tender, warmth. In a DVT, will it be bilateral or unilateral? Unilateral. So only one leg will be swollen. What's the Homan sign? Pain in the calf when you manipulate it. That's not very sensitive, but you can do it. If they have a DVT and you know that, and you do that, it may be positive, but it doesn't really mean much outside of that. May have inspiratory crackles or a friction rub, depending on the PE. So here are just some signs and symptoms of a PE. Chest pain, pleuritic pain. Here's your tachypnea, tachycardia. You're going to have there are EKG changes with a PE, and you'll get that in EKG, but there are some slight things. Obviously, T-wave inversion is one of them because we talked about the RV strain that occurs, so you may see some of those. So here is what a clot looks like. This is a PE. You can see how big they can get. And once they form, they start, they can start growing when everything comes past it. So obviously that was removed, and there was a big clot. Most perfusion defects can be corrected between 9 and 14 days. In some patients, the emboli gets very organized, like you see here. and gets kind of like attached to that pulmonary artery wall, becoming a very fibrous mass. This is a chronic pulmonary thromboembolism. It kind of just lives there. There are procedures, I can't remember what it's called specifically, but basically what you do is you get like a probe, a catheter, and the catheter goes right there, and the catheter itself just starts releasing, what medicine do we talk about that breaks up clots? Not heparin. TPA. Okay, talk about briefly, tissue plasminogen activator. What's plasminogen? It's going to break up the clot. So in people that have these chronic PEs and other clots in their body, they'll put a catheter right on top of that clot, and they'll just keep pulsing TPA directly on that clot until it breaks up and can go away. Another thing they'll do is, I think I have it here. No, I don't. I'll just give you the last one for me. If they have a DVT and they've had a couple of PEs, they do what's called the inferior vena cava filter, an IVC filter. So basically, you have your IVC, and what they do is they have like a little mesh that gets deployed, and it lives in the artery, or the inferior vena cava, sorry, so the vein. So it's in the IVC. So if any clots work their way up, they just get lodged in the net, and they don't cause you to have a PE. So patients who can't be coagulated, they can't be on warfarin at home for other reasons, but they have a risk of these DVTs with the PE, you put an IVC filter, and basically it's going to catch all the little clots that pop its way. Yes?
Wouldn't that like eventually cause a big clot right there?
Well, they're not throwing them consistently. It's just trying to catch the ones that do break off randomly. Once they get trapped there, over time, the body will dissolve it and they'll go away. Those things also, they're not permanent. They go in there for a little bit and then they take them out later on. But basically, that's the net. So, okay, let me just stop the recording. We'll start over.